Hello, everyone. Welcome to today's live broadcast, Emerging Trends in Heart Failure Therapy and the Importance of Natriuretic Peptides. I am Brenda Kelly Kim of LabRoots, and I'll be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots and sponsored by Roche Diagnostics. Roche is a leader in research-based focused healthcare with combined strengths in pharmaceuticals and diagnostics. They are the world's largest biotech company with truly differentiated medicines in oncology, virology, inflammation, metabolism, and CNS. Roche is also the world leader in vitro diagnostics, tissue-based cancer diagnostics, and a pioneer in diabetes management. For more information, please visit cardiac.roche.com. We have a few important announcements before we begin. This webcast is designed to be interactive, and we encourage you to ask questions during the event. You can submit your questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to answer as many of your questions as we can. You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. If you have any technical problems viewing or hearing this presentation properly, please click on the support button at the top right of your presentation window and submit your problem to the green Q&A button lower left. I would now like to introduce today's speakers. Dr. Rob Fitzgerald, our speaker today, is from the University of California, San Diego. Dr. Fitzgerald received his BS degree in chemistry at Loyola College of Maryland and his doctorate in pharmacology toxicology at the Medical College of Virginia Commonwealth University. After 2.5 years as a forensic toxicologist for the state of Virginia, he took a position as the director of mass spectrometry laboratory at the San Diego VA Hospital, where he worked from 1992 until 2011. Currently, Rob is a professor in the Department of Pathology at the University of California, San Diego, where he is the director of the Toxicology Laboratory and associate director of the Clinical Chemistry Lab. He is board certified in toxicology and clinical chemistry by the American Board of Clinical Chemistry. Rob's teaching responsibilities include acting as the course chairman for laboratory medicine and serving as the director of the Pathology Residency Clinical Chemistry Program and as the director of the COM-AAC accredited Clinical Chemistry Fellowship. I will now turn it over to Dr. Fitzgerald for his presentation.
Thanks, Brenda, for the introduction, and it's a pleasure to be here today to talk about natriuretic peptides. My talk is primarily going to focus on NT-proBNP, but I'm also going to show some data on BNP and how they compare. And really, the point of my talk is that both of the natriuretic peptides, BNP and NT-proBNP, are clinically useful. But there are a few differences that you should be aware of, and we'll go through that momentarily. So as far as conflicts of interest and background, I do get paid an honorarium. I have had research support from Roche as well as a variety of other clinical diagnostic manufacturers. So just as a bit of a background and review so that we're all sort of on the same page, I indicated that NT-proBNP, which is the molecule targeted by the Roche assay, and BNP, which is a molecule targeted by a variety of other clinical diagnostic assays, have a lot of similarities. And that sort of makes sense because they start from the same pro molecule. So proBNP is 108 amino acids long. Another take-home message is that these are markers of stretch. So myocyte stretch in the case of volume overload in heart failure, myocytes are stretched and they sense that and release both BNP and NT-pro. There's an enzyme called corin, which cleaves the pro molecule into an inactive fragment. That's NT-proBNP. We say amino terminus or NT-proBNP, the first 76 amino acids, and BNP, which is the active hormone, 32 amino acids with that cysteine connected ring. So that ring structure on BNP is also common in ANP and CNP, two other kinds of natriuretic peptides. Natriuresis means excretion of sodium. So along with sodium goes water, and you volume deplete. It also has direct vasodilating effect, so it is a hormone that's trying to counteract the decompensation mechanisms that are oftentimes renally related. So another important point about BNP is we'll talk about on the next slide. So just sort of a summary between the two. I've talked about the difference in amino acids. Half-life is clearly a difference between these two. So BNP has a half-life of about 20 minutes, and NT-proBNP has a significantly longer half-life. So acute changes might be reflected better by BNP. NT-pro, having a longer half-life, might be more sensitive in some screening cases. Another significant difference is stability. So BNP is unstable at room temperature, whereas NT-pro is clearly more stable, and we'll look at that in a couple of other slides. An important difference is the range, and this is confusing for clinicians if you're switching, because the range for BNP typically goes up to about 5,000, whereas the range of NT-proBNP can go to 35,000. So they're log distributed, and that can cause some confusion. Finally, the clearance, different mechanisms. BNP is cleared by a variety of mechanisms. One is an enzyme called neprilysin, and that's going to come up at the end of the talk because there's a new drug that actually targets that. And the mechanism of action there is to increase BNP levels to stave off effects of decompensation. So we're going to come back to that, but neprilysin works on BNP to degrade it, whereas NT-proBNP is not affected by that. So this is so the beginning of my talk is going to be more focused on the laboratory side because of important laboratory differences that laboratorians should know. And then we're going to go into some of the clinical utility of these two markers in different clinical settings, because I think it's important to understand that both from a laboratorian as well as a clinical view. So at the top we're looking at, so on the y-axis we're looking at percent of original value. On the x-axis we're looking at time in hours. And so in the orange line, it's pretty much straight across at 100%. That's showing NT-proBNP is stable over 48 hours. Whereas at room temperature, if a sample sits around for 4 hours, you get about a 30% decrease in BNP, and if it sits around longer than that, it can be up to 50 or more. So BNP clearly in vitro is unstable at room temperature. So a very similar slide looking at refrigerated. Again, NT-pro is stable, whereas BNP, although it's stable for the first 8 hours, after about 24 hours, you start to see significant decreases in concentrations of BNP because it's being degraded. And if you look at frozen, same thing. BNP is unstable, frozen. Now we've changed our x-axis to days. So this is time in the freezer at -20 versus NT-pro is quite stable, frozen. So a clear difference between these molecules is BNP is more unstable than NT-pro, a pre-analytical variable that you need to think about. There's also a fair amount of, I don't know, hype or myth or whatever you want to call it, that people say that BNP works better in renal failure than NT-proBNP. And this slide is a good example comparing both BNP and NT-proBNP in the setting of renal failure. So on the y-axis, we have concentrations of either BNP or NT-pro. On the x-axis, we have GFR, so decreasing GFR or increasing GFR. So as you move to the right on the x-axis, these are more healthy. And so you can say if you move from right to left, so if we're moving in this direction, you can see that BNP goes up as you get increased or decrease in renal failure. And the same thing can be seen here as your NT-pro. Now we're looking at same patients analyzed by either BNP or NT-proBNP. So interestingly, as GFR goes down, both of the natriuretic peptides go up. And clearly, this is at higher concentrations on the NT-pro side, And again, it has a bigger dynamic range, and so that's something to remember. What's also super important about this slide is if you look at this data. So these are patients with or without heart failure. So looking at the y-axis, we're looking at the with or without heart failure, and you can see that patients with low GFR that don't have heart failure have very low concentrations of NT-pro. And so clearly the increases of NT-pro in the setting of renal failure have meaning. So in the absence of renal failure, you don't get the same increases of NT-pro in the setting of chronic kidney disease. Another myth, or whatever you want to call it, about the differences between BNP and NT-pro is that BNP has one cutoff, and that's not a myth. It does have one cutoff. NT-pro has age-adjusted cutoffs. And the myth is that concentrations of BNP do not change with age. And so this is data taken from a variety of sources showing that BNP concentrations on the y-axis versus age on the x-axis, you can clearly see that as age goes up, so does BNP. In a very similar manner, if you look at NT-pro, it's almost the same kind of a slope. With age, NT-pro goes up. However, only NT-pro was approved at an age-adjusted cutoff. And so while it might be easier to use a single cutoff, it seems like there is value in adjusting for age. It is clearly has an effect on both natriuretic peptides. So analytically, some key points. NT-pro is more stable. That's a fact. The precision of both NT-pro and BNP on automated assays are quite good, so they fulfill, the ability to monitor within biological change of patients. NT-pro has a bigger range from 5 to 35,000 versus BNP has a more narrow range, and so if your clinicians are switching from one test to the other, that can cause issues because they're used to seeing things at lower concentrations, and these are log distributed. And so that is a challenge, and that's real. But they both have similar utility, and we're going to look at that shortly. So what about the biological variability? The biological variability of NT-pro is about 25%, and probably similar to BNP, maybe a little bit less. Clearly, age does have an effect on both natriuretic peptides, BNP and NT-pro. Women also has an effect, as well as body mass index. So there are a variety of variables that affect both BNP and NT-proBNP that clinicians should be aware of. So how is it approved to be used, and what do the major guidelines say? In 2013, the American College of Cardiology Foundation, American Heart Association, so these are the leading cardiologists. How do you use natriuretic peptides? And so a variety of ways to do that are approved. So Class 1, level of evidence A, so the highest level is the utility in diagnosis of heart failure. Also has a Class 1A for prognostic evaluation of heart failure, and Class 2 for achieving guideline-assisted and guidance for decompensation therapy. So switching gears a little bit from the analytical, we're going to talk about some of the clinical utility of the natriuretic peptides, and starting out with primarily what they were designed to do, and then moving into, we have really surpassed the vision for natriuretic peptides initially that they could just be used for diagnosis, and clearly they have some other things, and we'll talk about that. So next couple of slides are going to be on diagnosis in acute symptoms of heart failure. So studies similar to the breathing not proper trial that were done for BNP. This was looking at ED patients coming in, and they asked clinicians to estimate the likelihood for heart failure either low, so 0%, or they were pretty certain they had heart failure, 100%. And then they were blinded to the NT-pro results. So really this was how good heart failure is a clinical diagnosis. And so clearly I think no one is trying to say that the natriuretic peptide should replace a good clinical exam. And so physicians were able to do their routine clinical assessment. And what you can see from this slide is that 31% of the subjects, they were uncertain of the diagnosis of heart failure. So if they were 20% saying unlikely, they were saying that they were classified as certainly as not having heart failure. If they were 80% or above, they said that was in the certainty of having heart failure. So 31% of the subjects were in the gray zone or the uncertain zone. And what's interesting about that is that if you look at those patients, the natriuretic peptide was actually better than clinical diagnosis as far as the receiver-operator characteristic curve. And we'll look at that data in a second. But of that 31%, 50% had heart failure. So a large amount, half of the heart failure patients were in that group. So you say, okay, well, what happens with those uncertainties? And so they track that, and this is a hazard plot. So hazards go up on the y-axis versus days from presentation. And you can see in the sort of orange plot, the patients that were in the gray area, the indecisive area, had a significantly higher hazard ratio. So there were bad implications of not getting the diagnosis correct. What that slide is really sort of pointing out. So a lot of people are concerned if they're switching from BNP to NT-pro, how do they compare head to head? And so this was acute dyspnea, so acute shortness of breath, looking at NT-pro concentrations versus on the y-axis versus BNP concentrations on the x-axis. You see, there's a very rough correlation. You know, if you had a shotgun, you could sort of sweep it in that area. But as BNP goes up, so does NT-pro, and that's been our experience as well. So probably a better example of that is looking at this slide. So 251 patients that presented with shortness of breath. They got a BNP as well as an NT-pro, and we're looking at a receiver-operator characteristic curve. So if the tests are as good as flipping a coin, it would be along that dotted purple line. And you can compare tests by looking at area under the curve. So basically we're talking about on the bottom right area under the curve, and you see that the blue line and the orange line being NT-pro, blue line being BNP, pretty much overlay each other. So they have the same diagnostic efficiency for acutely decompensated heart failure. So both NT-pro and BNP work pretty well. So let's again look at the clinical judgment versus NT-pro. And so this is data where a Canadian study where clinicians were again either randomized to getting a BNP or not getting a BNP, and we're looking at receiver-operator characteristic curves. So the green line is clinical judgment. So that's without a natriuretic peptide measurement. And you can see that it has an area under the curve of about 0.83, whereas NT-pro by itself, without any other clinical acumen, you know, medical school, et cetera, a biomarker by itself had an area under the curve that was actually higher than clinical judgment. So pretty much equivalent, about 0.86. However, and the intended use of these products are shown by the orange line, where the highest area under the curve, if you add NT-pro and clinical judgment, and you compare that to clinical judgment alone, the p-value is quite significant. So it's quite clear that NT-pro adds to clinical judgment, and this study was really interesting because not only did it add to clinical judgment, but they actually followed patients to see how they did. So they looked at both the clinical and the economic impact. So that's the reference if you want to look it up. 500 patients that presented with shortness of breath at 7 different emergency departments in Canada. And basically, they got randomized to either getting an NT-pro or being blinded to an NT-pro result. 200 of that 500 patients, 230 of them had heart failure, and the median concentration of NT-pro in that patient cohort was about 3,700 picograms per mil, whereas the median in the patients without heart failure was 200. So quite clearly, some huge p-value differentiates those two. So clearly, NT-pro can differentiate heart failure from not having heart failure, but the power of this study is shown in the next slide. Not only did it identify patients, but patients that were in the NT-pro arm reduced their admission duration by 21%. The rehospitalization was decreased by 35%, and that sort of makes sense that if you're that much more efficient with getting your patients triaged appropriately, you reduce overall direct medical costs, and you take better care of your patients. So a really powerful biomarker study that shows not only that it works to diagnose, but it can actually improve outcomes both from a clinical as well as a financial perspective. So sort of a huge win for biomarkers. So in summary, NT-pro in heart failure evaluation general concepts, a lot of similarities with BNP. They're both stretch markers, so they go up in other things besides heart failure, but they generally have the same strengths and weaknesses. So differential diagnosis, it is important to remember these are stretch markers. There are other things that can cause stretch, and that they portend bad outcomes, which is prognosis and what we're going to talk about in a variety of different clinical settings. So here we'll look at prognosis in acute symptomatic patients. So it's a huge body of evidence that shows that both natriuretic peptides are associated with severity of disease. So increasing heart failure severity, you get increases in the natriuretic peptides. There are other comorbidities that you can use to predict outcomes, but NT-pro is independently prognostic of those other, such as ejection fraction, age, other comorbid conditions. And so as I pointed out before, is that natriuretic peptides are prognostic in other states besides heart failure, so more than just heart failure that causes elevations. So how often do you measure NT-pros? This is a study looking at post-treatment values and how patients did. So a survival plot again. So the orangish plot is where natriuretic peptides in the hospital actually increased by 30%. And so those patients did far worse in 200 days. They had a survivability that was less than 20%, or actually, sorry, cumulative rehospitalization. Whereas if in the hospital they decreased, if their NT-pro decreased by more than 30%, they clearly did better. And if they had a change that was less than 30%, clearly significantly different than patients who had big increases while in the hospital. So changes of NT-pro and BNP are important. So acute shortness of breath patients, any elevations of the natriuretic peptides seem to have prognostic value. So at presentation, an NT-pro is important, and then monitoring them typically after treatment. And what clinicians are trying to do there, you'll hear a term called a wet BNP versus a dry BNP. A wet BNP is a BNP in the setting of decompensation. And so in that setting, the BNP is going to be high because the patients are decompensated and the natriuretic peptides are trying to overcome the effects of the renin-angiotensin-aldosterone system. having a dry BNP is important because, and that's hopefully going to be after treatment. After the patient has been stabilized, they've gotten rid of the extra fluids. You want to know a dry BNP because that's really what's going to be monitored in an outpatient clinic, and what clinicians are going to be interested in determining if their dry BNP is changing. So by getting serial measurements, you can get both a wet and a dry BNP. And obviously, as I said before, these are used in the context of clinical care, so there are other clinical variables that clearly are important. So we'll switch gears a little bit and talk about prognosis in chronic heart failure. So chronic heart failure is difficult. There's a variety of models that have been developed based on age, ejection fractions, renal function, et cetera. But if you look at the prognostic utility of NT-proBNP and BNP, they're actually quite powerful in the setting of chronic heart failure. And they are independent if you do statistical analysis of other major comorbidities. So here's a study looking at 5,000 patients with chronic heart failure and looking at evaluating risk of mortality or hospitalization for heart failure. What this study showed is that natriuretic peptides have value. It's not just a plus or minus marker. So the degree of elevation has importance, and even the degree of elevation below the cutoff values for diagnosis. And so we'll look at that. So here is a cumulative probability of mortality for NT-pro based on quartiles. So patients were highest quartile, mid quartiles, and lowest. And so you can see that less than 374, the cumulative probability of mortality was low. As you go up in quartiles, you get increased probabilities of dying. Very similar plot, just looking at rehospitalization. Again, the same quartiles hold true, whereas these are NT-pro. If you look at how does BNP work, and a lot of people are concerned about the comparisons of BNP and NT-pro. So both of these are the cumulative probabilities show increased probability of mortality as you go up in quartiles. What's interesting about this is that the cutoff for BNP is 100, and you see even below the cutoff, there's importance in the concentration. So across the continuum of concentrations, both NT-pro and BNP have meaning. So final plot just showing the same thing for hospitalizations for BNP. So time in months versus probability versus the quartiles of BNP. Highest quartile has the highest probability for either mortality or rehospitalization. So in the setting of chronic heart failure, these patients are seen in the outpatient clinics, and doing serial samples, what does that tell you about either mortality or hospitalization? So if you start out NT-pro concentrations on the y-axis versus time in months, so this is a 4-month time span. If patients are low to start with, and 4 months later they're still low, they have a mortality of about 9% and hospitalization of about 7%. So low. However, if you look at patients that start high, so there was 1,000 patients and 1,300 patients in this arm of the study, 4 months later they were still high. They had 2.5 times the mortality rate, so about 25% mortality and about 27% rehospitalization. So high, staying high is bad. But really actually more interesting is what happens if they start out high and they end up low. If they start out high and they get on effective therapy and their NT-pro goes low, they have about a 14% mortality. And conversely, if they start out low, so this is 180 patients, started out low and went high, and they had an intermediate mortality. So clearly, that serial sampling is a signal that something bad, either mortality or rehospitalization, is a fairly high probability. So points about NT-pro in chronic heart failure. They're strong independent risk predictors, so they're independent of the other things that have clinical significance. They're useful across the entire spectrum of severity, so from both stage 1 disease to stage 4 disease. They clearly have effect. They're additive if you consider other patient variables such as renal function. So a couple of slides about, are the natriuretic peptides useful in ACS? So acute coronary syndrome, we typically think of troponins. And the major difference between troponins and natriuretic peptides are, troponins are necrosis markers. Troponins are saying myocytes are dying, whereas natriuretic peptides are stretch markers. They're saying myocytes are being volume overloaded and stretched. So typically we're measuring troponins to identify myocardial infarction, but what is the role of natriuretic peptides in acute coronary syndrome? So this is a study looking at separating natriuretic peptides on admission. So on the left side, we're looking at, NT-pro concentrations, so admission concentrations of less than 250, versus on the right side, we're looking at higher. So they're coming in at high. So that's the difference between those two. And what we're going to look at is what happens 3 days later. So while they're in the hospital for an admission for a suspected heart attack, 3 days later, what happens? So the green line, So the green line is they started out low. They had a low NT-pro coming in, less than 250, but 3 days later, when in the hospital, their BNP was elevated. And you see that their outcome, their probability of death, or MI, was about 18%. So what's interesting is if you take the patient population, same patient population, so these were patients that came in low and they stayed low, their cumulative probability of bad outcome was quite low. So that change while in the hospital has a big impact. And in fact, if you look at this, sorry, I'm used to using a pointer, so these arrows are a little bit funny. If you look at that green line versus that green line, this really shows the power of multiple measurements. So on admission and then at discharge, both of these, coming in, these patients look very different. Their baseline NT-pro on the left was low. Their baseline NT-pro on the right was high. Yet 3 days later, they both were on the high end, and they both had bad outcomes of similar probabilities. Whereas regardless if they came in low or if they came in high, this patient group came in high, but they went low and they had a low outcome, so a good prognosis. So while in the setting of ACS, we're looking for necrosis with the troponins, the immunoterminal pro-BNP does have value as far as prognostication. So NT-pro in primary care. How do primary care docs use natriuretic peptides? Shortness of breath, dyspnea, is a common complaint in primary care, and there's a variety of reasons that you can get that. So it is an important diagnostic dilemma. Ideally, you want to have a biomarker that has a good differential diagnosis, helpful, has good sensitivity and specificity, has something that you can actually make treatment changes on, and be cost effective. So we'll look at a couple of studies. So these were two different studies, about 300 patients each, looking at cutoffs for ruling out heart failure. And the optimal cutoff was 125 nanograms per liter or picograms per mil. And you see that negative predictive values were extremely good. And so ruling out heart failure and then looking at other causes. So how can it be used? Patients present with symptoms suggestive of heart failure. A physical exam. So as I've tried to say before, cardiologists are critical to this, and in primary care physicians actually doing a physical exam, because heart failure largely is a clinical diagnosis that the natriuretic peptides can aid. So a physical exam, EKG, and a natriuretic peptide measurement. If their natriuretic peptide is elevated, then they get worked up for having a possible cardiovascular cause. If their NT-pro is low, then they can look for other symptoms. And so how can that be used clinically? Here's a study that looked at what happens if you did an echocardiogram on all of the patients that were suspicious. So 367 patients, they did echocardiograms. Cost them $160 each time they did that, for a total cost of $58,000. However, if you use the algorithm that we suggested, where they got an NT-pro as part of the workup, and they only did echoes on elevated NT-pros, you ruled out 154 of that 367, so you only had to do 213 echoes for about $34,000. So total savings there is going to be about $10,000 on that 367 patient cohort. And you're avoiding doing echoes on 154 patients. So it includes the cost of doing a natriuretic peptide. So it does have some cost-benefit analysis. So interpreting heart failure in the setting of chronic disease, that goes back to what we talked about before, the wet and dry. So we pointed this out before. A dry BNP is a concentration of natriuretic peptide when the patient is stable, and that's when they come back into the ED, if they have a change in their dry BNP, so present to the ED with shortness of breath, they don't really know what the cause is. If in their chart they have a documented NT-pro in the setting of a stable disease, they look for a change of about 25%. So a 25% change, that's the biological variability. 25% change from the dry suggests that the patient has changed clinically and needs optimization. And as we've said before, that dry BNP is prognostic. So the last couple of slides I'm going to spend on are brand new. It has to do with a new therapy for heart disease. The drug is called ENTRESTO. And the reason that we're going to talk about it is because it does have an effect on natriuretic peptides. So prior to doing that, let's just talk a little bit about this drug. It has two different components, sacubitril and valsartan are the two components. Sacubitril, sorry, I'm definitely used to using a pointer versus an arrow. I apologize for that. Sacubitril is a neprilysin inhibitor. So from the beginning of the talk, we talked about how BNP gets degraded. Neprilysin is the enzyme that breaks down BNP into inactive fragments. And so if you inhibit neprilysin, which is what this drug does, you get higher concentrations of BNP. And that's good because BNP has a diuretic effect. It also has vasodilating effects, so all things that are going to counteract what's happening in decompensation. And the end result of decompensation, one of the end results is that you get increases of aldosterone that goes to the renin-angiotensin-aldosterone system. Valsartan is is part of this drug. So it's a combination of the neprilysin inhibitor to increase BNP, an angiotensin II receptor blocker, which is going to inhibit the ability to form aldosterone, and some of the angiotensin I things are going to cause increases in blood pressure. So combination of these two different drugs was sort of a novel mechanism, and it got compared with a very large clinical trial, about 10,000 patients, and we'll look at that data in a second. So valsartan is a drug by itself, an angiotensin receptor blocker. It was already approved, but this new combination with a neprilysin inhibitor adds a different mechanism of action that's additive in overcoming the decompensation mechanisms. So just to look at it again, how is it working? The drug has two components, the sacubitril and valsartan, angiotensin receptor. So if you block this side, you decrease the vasoconstriction, you decrease the sodium retention, and some of the remodeling effects. So an established drug. What's novel about it is on this side, the neprilysin inhibits the breakdown of BNP. So BNP concentrations are going to go up in the presence of this drug. And BNP, as we know, is a direct vasodilator. It causes natriuresis. If you have natriuresis, you get a diuresis. And it also has some effects on fibrosis. So this is the data, and this drug got approved this summer. It actually got stopped early because of the positive effect. So this is showing about 8,000 patients, more than 8,000 patients, and it was compared to an existing therapy. So enalapril is an angiotensin converting enzyme inhibitor, so a standard of care in heart failure therapy. And this is the ENTRESTO, and what we're looking at is really cumulative probably of a bad endpoint on the y-axis, and you can see that enalapril has a higher probability, and this p-value, when you have this many patients, is hugely significant. So if you look at all of the outcomes of this clinical trial, very powerfully for positive outcomes. So very little adverse effects in this combination. So the heart of the matter is shown in this slide, and this is why both cardiologists and laboratorians are interested. So we're looking at this is the clinical trial data and what's happening to the natriuretic peptides. And so patients that are on enalapril in the blue, you can see patients on enalapril, their BNP goes down with therapy. However, patients on ENTRESTO, their BNP actually goes up. And that's what you would expect. You would expect their BNP to go up if they're being treated effectively and they're recovering from heart failure. Then their NT-pro goes down because the stimulus for endogenous secretion is decreased. So very positive drop in NT-pro on ENTRESTO. That's not quite as evident on enalapril. So how does this affect diagnosis? And so from a diagnostic standpoint, I think this is important because if a patient comes in decompensated on this drug or suspicions of being decompensated, it's going to be difficult to use BNP to make that diagnosis because the effect of the drug is to increase BNP. However, the same patient, if they're monitored using NT-pro, their NT-pro should actually be indicative of their endogenous heart failure status because NT-pro is not affected by the drug. And that's really what that summary slide shows. What was sort of almost radical about this is the United Kingdom actually came out with a statement that says, this drug study was an international study with about 10,000 patients, so a huge study involving, international collaborators. So potentially could have a big impact on, how many patients eventually get put on it. And, the jury's still out on that, but it does seem to be an effective drug therapy for heart failure and new mechanisms. Anyhow, what they said is that BNP is not a suitable biomarker for heart failure in patients treated with ENTRESTO because BNP is a substrate, and NT-pro is not a substrate, therefore is a more suitable biomarker. We haven't had any statements similar to that in the U.S., and really I think, it's early, and we're going to see, more data is going to be coming out on that as to whether one is better than the other. It could be that BNP is used to see how effective the drug is working, and NT-pro could be used to monitor endogenous secretion. So there's a lot still to be learned on that, but potentially from a diagnostic standpoint, important to know. So with that, I'll thank you for your attention and be welcome to taking any questions.
Thank you, Rob, for that informative presentation. Before we get started on our audience questions and answers, I would like to remind them how to submit their questions. Questions can be submitted by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to answer as many of your questions as we can. And with that, we will get right to our first question. Attendee asks, is there a need to convert to NT-proBNP if I'm using BNP, given the fact that ENTRESTO is not on my hospital's formulary yet?
So I think ENTRESTO is not on a lot of hospitals' formularies currently, but I think that laboratorians need to be out in front of this because if it is on the formulary and a lot of patients eventually get put on it, then it will cause some confusion if you don't know, whether or not the patient's on it. So currently, do you need to switch? I would say that's premature.
Great, thank you. Our next question, how do you suggest the change from BNP to NT-proBNP be accomplished with clinicians who are following patients in an outpatient setting? We just tried to switch once and got tremendous negative feedback, so we had to switch back to BNP. Would you suggest offering both BNP and NT-proBNP for 6 months or so?
I think that's essential. I think that laboratorians need to remember that docs see patients every day, and they have relationships with patients, and they have been monitoring their labs, so they sort of have a gestalt about what changes are significant. And to make a blind switch without informing your clinicians is a bad idea. We here at UCSD, we face a very similar challenge. In fact, the original BNP trials that showed that BNP was a good biomarker were done here at UCSD at the VA that's associated. And so all of our clinicians, from our residents to our fellows to our faculty, had sort of, been brought up in the world of BNP. And so the change for us was probably harder than most places because of the history of the biomarkers. And so in our setting, we actually did a 6-month comparison where we gave both values. And in fact, the data showed that both of them agreed quite well. We could show some slides if you think that that's warranted. But
okay.
So clearly, it's at least a 6-month process. Talk to your laboratory vendors to see if they can help you out with costs of doing that, because it is an important change and should be done in collaboration with your clinicians.
Okay, did you have slides you wanted to show on that, Rob?
Sure. So this is 500 patients that we did here at UCSD, and again, the level of hostility here was significant because they were brought up on BNP, and making that switch was challenging. So looking at 500 patients, and what you can see is that, 203 of them were negative by both assays, and 278 were positive by both assays. So out of 500 patients, we had 10 that did not agree. And if you think about it, that's actually amazingly good. And so we sort of took the view that we would call these false positives and we would call these false positives. We were really not making a judgment on which one was right, and we wanted to see what happened to those patients in time. Typically, in our hospital, if they're concerned about heart failure, decompensation, they're going to order sequential samples while they're in the hospital. So let's look at those 10 patients, so what we're calling the false positives. So here we're looking at part of what we did was, according to the College of American Pathologists, what you should do is evaluate reference ranges. And so we looked at reference ranges that were used in international studies and actually adopted the ICON reference ranges. So what we're looking at here is the two patients that we called false positive by BNP. So they were positive by BNP but negative by NT-pro. And so important to look at the age group. So that's what we're looking here, less than 50 and 50 to 75, because we have age-adjusted cutoffs for NT-pro. So barely positive by BNP, cutoff being 100. There was not a second BNP. Here in our laboratory, we use a cutoff of 450 for diagnosis. So negative by NT-pro. And what happened with that patient? This patient was status a heart surgery, and they actually weren't sufficiently concerned to do a second natriuretic peptide sample. So unclear. Second sample, that was a false positive BNP, barely positive. Actually, both of these are really within the error of the measurement, probably, of being positive or negative. So just barely positive, so 102. 900 is our cutoff in the age group of 50 to 75. So negative by NT-pro. Only thing in this patient's medical record was they were out of control diabetic. So again, they didn't order a second natriuretic peptide. So let's look at the last group, and this was what we called false positive NT-pros. So again, we have 3 of the patients were lost to follow-up, so there was no follow-up, so we couldn't really determine an outcome. Different age groups, less than 50 or 50 to 75. Initial BNP in this patient was 97. NT-pro was 950, so clearly positive. This patient had a bad outcome, but they didn't order a second, so we couldn't really evaluate trends. Again, second patient, interestingly, negative by BNP on admission, so this was the first value, whereas it was positive by NT-pro. So this put it in a false positive NT-pro. If you look at what happened, the second BNP sample was positive, so sort of confirmed that this was an elevation of natriuretic peptides, and the second NT-pro also was positive. So here, NT-pro was positive before BNP. That was sort of the outcome. Patient had a cardiomyopathy. Third patient, same thing, negative on initial BNP, positive on second BNP, positive initially, and stayed positive on NT-pro. So pulmonary embolus. So again, there are other causes for elevations of natriuretic peptides besides heart failure. So very similar, negative by negative by BNP goes positive. Second sample is positive, whereas initially it was positive for NT-pro and went sky high. And so patient had a diagnosis of heart failure. This last one is probably a kinetic thing. So started out negative and went even more negative for BNP. We talked about the half-life of BNP being shorter than NT-pro. NT-proBNP being positive and going negative. So half-life issue, patient had a diagnosis of heart failure, so, you know, sort of understandable how those labs came to be. So we sort of concluded that NT-pro was more sensitive because it was becoming positive before BNP, and that BNP was subsequently becoming positive 3 of the 5 discrepant patients. So that's sort of a long-winded answer to a short question. So I'd be glad to take it.
Thank you, Rob. Our next question, how would you recommend approaching the topic of ENTRESTO with clinicians?
I think first off, you need to find out if they're using it or if they plan to use it. So I think one of the things, this is an opportunity for laboratorians to get out of their office. So make a contact in the cardiology department. Let them know that you understand that this new drug is available, and you want to have a conversation with them about how your lab is doing biomarker testing, and is that going to impact how they take care of patients. So a great chance to reach out and contribute.
Great. Our next question, moving along. Are there any significant known interference with NT-proBNP determinations versus BNP, such as antibiotics, hemolysis, medications, etc.?
There are no, so there are, I'd have to take a closer look at the package insert. My recollection is that there are less, like we say, serum indices, hemolysis, icteric, lipemia. I think there are less for NT-pro versus BNP, but at some, at some level, all of the tests are, are affected by serum indices. As far as other things that would be like antibiotics or things like that, I'm not aware of any that interfere.
Great. Our next question, what do you suggest is the correct serial draw or collection times for assessment of NT-proBNP?
So I think that really depends on the clinical situation, whether or not they're in the ED or if they're being monitored in an outpatient clinic. And so in the ED, I think our cardiologists really like to have on admission and close to discharge. Again, on admission is going to be the wet BNP, and they want to know what the dry is for lots of reasons. One, did they get good care? Were they able to, in the hospital treatment setting, did their BNP drop? And that's going to give them prognostic information, how closely the patient should be followed, how tightly their meds should be monitored, et cetera. Versus in an outpatient setting, then I think it's, it's going to be clinician dependent.
Great. Thank you. Another question from one of our attendees. What steps did your facility take to educate and prepare all clinicians and lab for a switch from BNP to NT-proBNP?
We took a lot of steps because we knew that it was going to be a major change. And so we actually worked with Roche to develop a plan. Started out with I reached out to the director of cardiology and told him what we were thinking about. And really we make decisions on laboratory platforms based on our whole healthcare situation. We're not going to make a decision to implement automation and all the other things associated with changing vendors unless we can take care of all of the patients. We're not taking care of just cardiology. So I think we need to, bring that to the table. Like, we're trying to improve patient care for everyone in our hospital that we're responsible for. And as part of that, we're going to be switching over. And so started out with, at the high level, we had seminars that were, I conducted some of them, Roche Medical Supports conducted other ones at all lines. So on the nursing level, on the laboratory side, on grand rounds to cardiologists, and really sort of what turned the table for us was, our cardiologists really didn't want to hear from a laboratorian about how to take care of their patients, and that's understandable. They are the front line. They interact with patients, directly, and so we actually brought in an outside cardiologist who could give us an objective view of the natriuretic peptides, and then that allowed us to really have a much better conversation.
Thank you, Rob. That is all the time that we have for our audience questions right now. I'd like to thank Rob Fitzgerald again for his presentation and ask him if he has any final comments for our attendees.
I really don't have any final comments. I think that the natriuretic peptides have made a big change in healthcare and in a very positive direction. And so, we need to continue to offer that. We need to be aware of changing therapies and how they can affect patient care.
Thank you, Rob. We appreciate your time today in bringing this information to us. I would also like to thank our sponsor, Roche Diagnostic, for making today's educational webcast possible. Today's webcast will be available for on-demand viewing through June of 2016. Attendees will receive an email from LabRoots alerting you when this webcast will be available for replay, and we invite you to forward that announcement to your colleagues who may have missed today's live event. That's all we have. Hope to see you next time. Goodbye.